to just keep loving you. Thank you for loving me, yeah. Thank you for loving me, yeah. Oh, and I thank you for always loving me. And it's probably no matter what I do or I say, you still love me. And regardless of every mistake that I make, you still love me. And I know I don't have everything that it takes, but you love me. Oh, even with the pimples on my face, you still love me. So you just keep loving me. Yeah. Thank you for loving me. Thank you for loving me. Oh, in spite of me, you were there loving me. But I thank you for always loving me. Amen.
Also known as the social determinants of health, they include things like our income, housing, education, or job opportunities. Discrimination can make being healthy even more challenging. When some groups face barriers within these determinants more than other groups, this is unfair, and we refer to these as inequities. Some inequities may begin in the womb and continue throughout childhood and beyond. Canadian children living in communities with lower levels of education, employment, and income have lower chances of reaching their full developmental potential. Inequities continue into adulthood. For example, Canadians with lower levels of education, employment, or income are more likely to have diabetes and poor mental health. Ultimately, people with lower levels of education or income live shorter lives on average. Other social determinants also affect our health and well-being, such as food and housing. Certain Canadians experience food insecurity more than others. That means they are unable to afford the quantity and quality of food they need for good health. First Nations on reserve, First Nations off reserve, Inuit and Métis people experience higher food insecurity than non-Indigenous people. Black and Latin American Canadians experience higher food insecurity than white Canadians. Bisexual people experience higher food insecurity than heterosexual people. There are also inequities in access to adequate, affordable, and suitable housing. Recent immigrants are twice as likely as non-immigrants to live in housing that is unaffordable, too crowded, or in need of major repairs. Inequities experienced by First Nations, Inuit, and Métis populations are anchored in colonial policies and practices that included forced displacement into reserves and remote communities, the banning of Indigenous languages and cultural practices, and creation of the residential school system. Unaddressed intergenerational trauma adds to the ongoing challenges faced by Indigenous peoples. How do we address these inequities? By ensuring the conditions that support our health, such as good housing, income, education, employment, social connectedness and access to social support, and health programs and services are equitably available to all Canadians. For Indigenous peoples, this would include addressing the calls to action as outlined in the Truth and Reconciliation Report and United Nations Declaration on the Rights of Indigenous Peoples. Doing this requires a better understanding of the current state of health inequalities in Canada. This information is now available in the Key Health Inequalities in Canada report and the Health Inequalities Data Tool, so that together we can create opportunities for all Canadians to enjoy optimum health and well-being.
Good evening, everyone, and welcome to this evening's program. My name is Kayla Burt, and I work at Public Health Ontario. Just before we get started with the discussion with Dr. Timothy, I'd love to give an introduction. Dr. Timothy is an assistant professor in the teaching stream and is the new director of health promotion at Dalla Lana School of Public Health at the University of Toronto, and an adjunct professor in critical disability studies at York University. She specializes in the areas of Black health, intersectionality, violence and ethics in health work, health and racism, art-based methodologies, transnational Indigenous health, and anti-oppression, anti-colonial approaches to mental health. Dr. Timothy has worked for over 30 years in community health, working on resisting anti-Black racism and intersectional violence strategies. She has been living with a visual disability for over 25 years. Dr. Timothy is also co-founder and consultant at Continuing Health Healing Consultants, where she implements and teaches her intersectional mental health model, anti-oppression psychotherapy. She is an interdisciplinary scholar, health practitioner, and political scientist who examines global health and ethics from a critical trauma-informed decolonization framework. Her current research is entitled Black Health Matters, National and Transnational COVID-19 Impact, Resistance, and Intervention Strategies Project. So welcome, Dr. Timothy. We're glad to have you here with us.
Nice being here today.
From the video that we just saw, it described health inequalities, but I think the discussion that we want to have today is more so on health equity and health inequities, which is a difference. It's a different terminology. Would you be able to provide a couple of examples of what health equity looks like from a public health type of point of view?
Yes, first I'd like to actually use the definition of the World Health Organization. I think it's a good one. Health equity is defined as the absence of unfair and avoidable or remediable differences in health among population groups defined socially, economically, demographically, or geographically. Health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So there is, it means that that health equity is that there's inclusion and that folks can receive, access to healthcare and good treatment, no matter their race, class, gender, and other factors such as that.
Thank you for that definition and example. And this is something that is more prominent in discussions in healthcare about really trying to achieve health equity. There's lots of gaps right now that need to be addressed and looked at. And in the Canadian context specifically, what are we seeing when we look at the different health inequities as it relates to Black people and people of color?
Well, we know that that there's a disproportionate health inequities in terms of Black, Indigenous, and what I call racialized and what I call purposefully marginalized communities, that people are living in more housing, they have more housing issues, more food insecurities, housing insecurities, employment, more employment, underemployment. In terms of educational attainment, they're not getting the jobs even if they have education. So those are some of the examples. There's also health inequities in terms of care. We know that there's more chronic health issues for the Black community and Indigenous communities in terms of diabetes, high blood pressure, HIV rates, and that there's a connection to health disparities and issues of racism, sexism, and other types of intersectional violence.
Yes, thank you. I think it's important that people realize that anti-Black racism is a public health crisis, and that does really contribute to poor health outcomes in our communities. And sometimes that results in deaths, as we've seen this past year with all the police brutalities going on within our country and abroad. So that was just declared as a public health concern just recently, a couple of years ago.
Right.
So I think we're going in the right direction, but there's so much work to be done and awareness to bring forward. And so, as you just described, those different types of intersectional factors that contribute to the different health inequities we're seeing among Black, marginalized, and racialized groups. They already existed pre-COVID-19.
Yeah.
And now, COVID-19, we're seeing that the pandemic right now, Black communities are overrepresented in amount of people that have been infected with this virus. Could you speak to that, and what are the reasons for that?
Right. So before I speak to you about that, I just want to talk a little bit about the history of health violence in Black communities. So there's reasons why the Black community is disproportionately being impacted by COVID-19. They were before in terms of health disparities, and now COVID-19, we see that it's been intensified. So people of African ancestry in Canada have a history of colonial violence that started in villages throughout the African region as families were brutally torn apart and separated forever on the shores of African enslavement ports. That through the Middle Passage and focused migration to the Caribbean, Latin and South America, Europe, United States, and Canada, to name a few, this made up the transatlantic slave trade. Black folks that survived were then bought as property, and generations worked with no pay and with daily experiences of sexual, physical, mental, spiritual, and financial violence. The ethical practices of colonial violence on the lives of Black communities locally and globally are directly related to transgenerational trauma and health disparities, which impact Black health today. So the history of the Canadian context of slavery and enslavement is really important to understand. Also, the immigration policies that banned Africans immigration to Canada, which is from 1867 to 1960, and these policies are really important to understand. We have over 1,198,540 people of African Black ancestry in Canada, representing 3.5% of the total population who live in Turtle Island, Canada. 21% of reported cases of COVID-19 affect Black people, who make up only 9% of the city's overall population. And this has to do with the health impact of racism and racialization. The underlying conditions related to racism, which is intersectional violence and transgenerational trauma, equal increased risk. So we are at increased risk based on the history of anti-Black racism and current day's experiences of exclusion. There's also mistrust in the healthcare system due to past experience of health violence. There's biases by health practitioners. We're also working in low-paying jobs and have food insecurity. There's an overrepresentation in service provider work, PSW, migrant, cleaning, nursing, et cetera, essential worker jobs, working in TTC, et cetera. There's also the experience of racial profiling and police surveillance. The fact that people went out during a pandemic to protest anti-Black racism tells you the conditions of anti-Black violence in our communities. There's also overcrowding in housing, and there's also real beliefs that Black people don't feel the same amount of pain that white people feel in terms of our healthcare system. So there's a lot of ideologies and practices that are problematic that now have increased the intensity of COVID-19 for Black communities in Canada.
Thank you so much for providing that background detail about the history of anti-Black racism and health inequities in Canada specifically. I know a lot of people are used to hearing about the context from our neighbors down south in the States, but it's good to get that information from where we are living and growing up. And it is interesting to hear some people that I know that went to like med school or whatnot, and they're reading those textbooks, and it's really based on white data, white people. There's no information on how to identify different illnesses on brown and Black skin. It's so there's already it's kind of set up against actually doing healthcare for people who are racialized in communities. So there's lots of different levels and layers where this is apparent. And so thank you for providing that additional context. Before I move on, I'd like to let everyone know that you can put in your questions in the comments box that's there. We will address them in the last half of this program. So feel free to ask any questions about health inequities and COVID-19, health inequities among Black people and racialized, marginalized groups. So the overrepresentation that we're seeing in Canada, specifically Ontario, when it comes to COVID-19 cases among Black people. Last May, Region of Peel put out some data that they collected on race data and COVID-19, as well as Toronto region actually provided some last July in 2020, and they reported that 83% of the people that reported COVID-19 infections identified with a racialized group. And that is very significant because the Black population does not represent most of the majority in Toronto or in other parts of the GTA. So that just shows the overrepresentation. There's more of us being sick. However, there's less people that are Black compared to the rest of the population.
Right.
So would you, I guess, reiterate again the types of people that we would probably be seeing in those groups that are being overrepresented? What type of jobs are they? Occupations do they have, which might give some light onto why we're seeing these numbers?
Well, in terms of the Black population and racialized population or Indigenous population, we're working in essential work. So we're PSWs. We're working in the hospital. We're nurses. We're also working in grocery stores as clerks. We are working in the TTC. We're driving buses. We are cleaning in hospitals. We do have are smaller numbers of people who are doctors, but we're who are also essential workers. We're also doing food pickups. There's a lot of Ubering and a lot of food pickups that have happened or increased during COVID-19. A lot of folks who are doing those jobs are Black, from the Black community or from racialized communities. So we're in positions in terms of the workplace that actually make us we're also working in long-term care services. So we're in positions that make us more vulnerable also to getting COVID-19. And then in our housing conditions, we're living in housing conditions that have either overcrowding in housings or having, multiple generational families in housing. We're also not living in big spaces. We might be living in apartment buildings or huge apartment buildings with, a lot of neighbors, unlike other folks who are living in, individual dwellings that have space. So social distancing becomes more challenging for Black folks based on, the impact of anti-Black racism, based on our income, what we have, based on the housing that we're living in and the jobs that we are doing, et cetera. I also want to say that there's an increased amount of Black folks who have also been impacted from COVID-19 and racialized folks in terms of losing job based on COVID. So there's been a lot of closing, down of certain organizations, and that has also impacted Black and racialized folks. We're also working in factories. We also need to talk about the migrant workers, that we know that there's a large number of migrant workers who come from the Caribbean, who come from Central America, who have COVID. And so coming to work in Canada, we did not protect, workers who were vulnerable, who come from, communities, racialized communities, Black communities, Indigenous communities. They're doing our farming, they're doing all of these things that benefit Canada, but we're not protecting them. We didn't protect them, and they're getting higher rates of COVID-19 with living in very, very problematic conditions also.
Thank you for pointing that out, how the stay-at-home orders or recommendations are not as easily, done for some certain populations, especially for those who, as you said, live in overcrowding homes or apartments. There's not much social distancing that can occur there. And then also those who have, as you said, PSW jobs or working as nurses or sanitation workers who have to go out to provide for their families. They're just, I guess, putting themselves at increased risk by being exposed to more people and being outside. So it's important to understand the sensitivities and the nuances, I guess, when we're putting out some public health recommendations or advice. But as we do that, we should also recognize that not everyone's able to do these things and provide, support for these people.
I also want to mention there's also undocumented people who are here who don't have papers, and that becomes even more complex and more intense in terms of their experiences. Also, there's a lot of people living in shelters, different shelters, homeless shelters, or shelters in terms of abuse or youth shelters, who are also living in conditions that are more susceptible to getting COVID-19. We also need to talk about the imprisoned, and we know that there are higher rates of Black and Indigenous people imprisoned, and directly that's based on anti-Black racism and anti-Indigenous racism. So again, these populations that we're talking about in our communities, there's histories and histories of why how anti-Black racism and policies have created these types of detrimental health conditions that now, looking at COVID-19, are impacting us in a more severe way.
Thank you for that. I think we can have a short break if that's all right. And I believe that there's a video that we can provide.
Thank you.
In Canada, we take pride in our universal, publicly funded health system. As Canadian residents, we have free access to physician and hospital services no matter what part of the country we live in, where we've immigrated from, or where we work. However, access to healthcare is one of the many factors that determine health. Healthcare systems also need to consider things such as social supports, healthy child development, physical environments, income, and education. These factors are called determinants of health and play an important role in contributing to healthy populations. Meet Eddie. He lives in a low-income neighborhood where he is excited to start grade 1 so he can ride the bus to school. He's just been hospitalized with asthma for the 3rd time this year. Analysis by the Canadian Institute for Health Information, also known as CIHI, shows that hospital admission rates for asthma have on average dropped by 50% over the past decade. This is a good thing. But what about Eddie? What if we told you that some children are admitted to hospital more often than others? Meet Sandra. She lives in a high-income neighborhood where she walks to school with her dad and will be starting grade 2. She also has asthma, but hasn't been hospitalized since she was diagnosed as an infant. According to CIHI analysis, asthma hospitalizations are 1.5 times more common among children living in low-income neighborhoods like Eddie compared to children living in high-income neighborhoods like Sandra. A difference in health across population groups, such as the low-income and high-income neighborhoods, is called a health inequality. Sometimes health inequalities are unavoidable. For instance, when a health difference can be attributed to a biological factor, like your DNA. Other times, health inequalities are unfair and avoidable. This type of inequality is considered an inequity, like differences by income level. By eliminating unfair and avoidable differences in healthcare access, for example, we can achieve a more equitable health system. Measuring and understanding health inequalities is a critical first step towards informing action to improve health equity. This is because averages do not tell the full story. For example, earlier we told you that the average asthma hospitalization rate has decreased in the last decade. However, looking at the overall average does not show how many more kids are being hospitalized from Eddie's neighborhood compared to Sandra's. Healthcare systems can use information on health inequalities as they seek to improve access to quality care and health outcomes. Ultimately, health systems strive to ensure that these improvements are shared across the entire population. So how exactly do we measure inequalities? We can do this by measuring and reporting on indicators by population groups, such as Canadians living in richer and poorer neighborhoods like Eddie and Sandra. We call this equity stratification. At CIHI, we stratify indicators in different ways, including by age and sex, and increasingly
Okay, we're back after that little short break. I think this is a good segue into, I guess, data collection and how that's being done around, different determinants of health and health inequities, especially when it comes to COVID-19. I mentioned a bit earlier about the region of Peel and Toronto doing some of this work. Could you speak to a bit about how important it is to understand a key understanding of which populations are being impacted and what measures need to be done based on those data and how that collection should be done? Because I believe that you do have yourself some research currently going on to address the Black experience of COVID-19. So if you can give some explanation about that whole data collection process and then also your research, that would be greatly appreciated.
Thanks, Kayla. So the question of data collection is actually something, particularly race-based and intersectional data collection, is something that Black particularly Black communities, talk about Black communities, were requesting and talking about for many, many years. Actually, it happened based on a lot of police violence in the community and kind of wanting to know statistics in terms of, what was happening in terms of police brutality. Now, what happened during COVID-19, basically in March, as the numbers, we realized that there were Black people disproportionately were being impacted by COVID-19. Black health leaders in the community were basically, there's a statement that was sent out, and people were really concerned about not having race-based data collected regarding COVID-19. And the reasons that they were saying that they're not going to collect race-based data initially was about confidentiality, that there was about confidentiality, and that in fact it wasn't important, that race was not a factor for COVID-19. So I say that because I was one of the people, and many Black community leaders were saying we need to collect data, and there's importance to collect data, and we were told by public health that that's not something that we want to do or that is important. Now there has been a change, as we know that now I think late April, in May, Toronto, Peel are collecting data, and Ottawa also collecting data. There's still in other provinces like Quebec, it's still a very difficult issue in terms of collecting race-based data. So the need for race-based data, why do we need it? Well, we need the race-based data, even though we know that there's disproportionate numbers, we need it to actually prove, right? We want to prove the facts that there is an impact, that we know that there's a lot of community health centers and hospitals who also collect data, but as I said, that lots of that information is confidential. So race-based data will give us a bigger picture of what's happening within the community, and therefore the interventions and strategies that we create to support and help and hopefully lessen the numbers of cases of COVID-19 for Black communities can happen as we know these numbers. So as we know the rates and of why and how people are and what the numbers are in terms of people getting COVID-19, we can then create interventions. So my research project came about from I was tired of talking and going around and talking about the importance of race-based data, and I decided to start a research project in terms of collecting data. There's some other folks who are doing different types of project in terms of data, because the importance of data will give us the numbers again to create these interventions that we need to support well-being and health in our communities. So from that, I decided to I also want to say that Black-led research is very difficult to be funded in our communities, and thankfully I did get funded from Dalalana and also a private donor who thought that it was really important to help in terms of race-based data collection. And my research is, Black Health Matters National and Transnational COVID-19 Impact, Resistance and Intervention Strategy Project comes from the community. So it's a community-based project which is led by Black researchers and community members. We have an advisory committee of 25 amazing people who are working in community health, who are working in scholarship, who work from Nova Scotia, British Columbia, Quebec, Ontario, Ottawa, Toronto, who are looking to support getting the data collected. We have a survey, a national survey out right now that looks at the impact, looks at how people also are resisting, fighting back, and looking at the interventions that are working in our community. We also are launching a global survey. As we know, Black folks are connected to many other places and spaces, so that when COVID-19 is impacting our community in Toronto, it's also impacting our communities in the Caribbean, in Africa, in Latin America, in UK, in the States. So we're also creating a global survey, which will be launched on March 21st, which is the International Day of Racial Discrimination. And we also are going to be doing a whole bunch of focus groups also to focus groups with CAS workers, with nurses, Black nurses, with students, Black students, with folks who are on disability or living with a disability, all kinds of folks to really look at the heterogeneous impact. There's many different types of Black people who are being impacted, and we really want to know. We also want to know how people are surviving and also what intervention strategies are working. We hope to also include migrant workers and also people who are working in different essential jobs. Please take the survey. It's blackhealthmatterscovid19.ca. We really want your voice to be heard. One of our major themes is it takes a village, and we really believe that this survey and this research is about empowering Black community to take back their health and take back their well-being.
Thank you so much. It's so important for the community to recognize and see that there are people that are in professionals in these fields that are working towards, addressing some of these issues that we're facing. And I think it's also great just to know that it's being led by Black professionals. I think there's a certain trust that's there, right? We have an understanding that they do care and that what they have to say does matter and that it will be addressed to some degree. And at the bottom, there's a link there just to go and check out the research that's going on, and you can participate by doing the survey. This is kind of a good segue to my next question. So we're kind of seeing some of the initiatives that are going on right now, and your survey is a way for everyone to participate in some way. Is there anything else that we as individuals can do to help address these inequalities? Not just for COVID-19, but just what we see in our healthcare, in our communities, and how we can be participants of that work.
I think that's a great question. I think we all have different locations, social locations, and as Black folks, I think it's important to look at our mental health and to look at how we can continue to support each other as a community. So I know people who are sharing meals in terms of not together, but like either having like a Zoom meal time or different things, or bringing food to people who are dealing with COVID-19. I know a lot of folks who are doing that. There's people who are supporting people in housing. There's a lot of different things that you can do. I think the number one thing is to keep on doing social distancing and protecting yourself as much as you can. Get as much information as you can in regards to about COVID-19. What was the other part of the question? Sorry.
Oh, just about, what can we do to, I guess, bring awareness to these health inequities, right, participate in that discussion and that work.
Right. So I think my first point is to take care of yourself as much as you can, right? We know that self-care and community care is critical to our health. In terms of health inequities, there's different ways that you can, your politicians, you can, write letters, get involved in different health equity programs or, policy. There's different policy groups that are important that you might be able to, be involved in. I think that getting awareness is the number one thing. I think also if you're an active ally, which means that you might not come from the Black community, but that you have some power in terms of your position and your social location, talk to people, make changes. When you hear a racist joke in your organization or work, address it. There's different ways that I think that you can advocate for health equity. I think that when I think of health inequity, I think about ethics, and I think how do you make ethical decisions on a daily basis in our lives? Like how do you choose to be ethical and to practice real equality and inclusion for people? Sometimes I have a question like, can you teach people how to be empathetic? Like, can we teach empathy? I think empathy is a really critical piece in terms of health equity. People who are suffering, people who are dealing with these not only discrepancies but disparities are human beings. So come with love, come with resources. We also need resources to do our programs. Maybe supporting your local church, maybe giving food, bringing food to families who might not have food access. How you actually take up space to address anti-Black racism in your workplaces, in your schools, are all important to dealing with health inequities.
Thank you so much for giving people lots of options. So basically you can be a part of this discussion and this work by just being there for people around you, making sure that you're standing up for yourself and your rights, and that there's not just up to the people that work in healthcare that should be addressing these, but everywhere, everyone, wherever you go, you have this opportunity. And you touched on something important about self-care, and especially during this quarantine pandemic period, that's been a big question. People that live alone, people that live in some, abusive homes, people that, have long distance relationships with their family members, can't go visit them, the sick people that are living by themselves in nursing homes. There's so many different, iterations of that. And I think about sometimes, what would I be doing if I was in school during this time? It's so stressful right now. Could you speak to like mental health and COVID-19? I think people would appreciate some points on that.
Yes, definitely. I'm also a psychotherapist, so I see clients and I also train therapists and also support therapists in clinical supervision. So we know that the impact of COVID-19 and mental health. There's been a lot of job loss, right? There's been food and housing insecurity, it intensified. There's increased fear, increased isolation, increased stress and depression, increased anxiety, and increased grief. Most Black, Indigenous, and racialized folk have actually know somebody or experience some type of loss in COVID-19, so that we know that these impacts have intensified in terms of distress in our community. So, there's certain things that you can do to seek support is one of them. To seek support from your family or from your pastor or from a therapist or a group. Also in terms of isolation, it's very hard based on social distancing. So, things such as phone, some people have Sunday night phone calls or, Wednesday night meetings where they, you eat dinner together. And it sometimes it's like, oh, I don't really want to do it. I don't feel up to it, but really trying to get out there and do different things, even though you're social distancing. Also, walking and exercise is really good. Stretching. I always say, if you don't have access to go walking because it's not safe, in an environment that you're living, you can walk in your house. It sounds funny, but walk in your house, it doesn't matter what the space is, that's the beginning of doing some healthy exercise, which will help your mental health. So also talking to people, I think, is important, but we know that some folks are not doing that based on isolation. So maybe, you might not have heard, maybe an elder in your community, or you might not have heard a friend call you in a couple of weeks. Give her a call, send her a text. There's different things like that would really make a difference in people's lives, particularly based on the mental health crisis that people are dealing with right now.
Thank you. Self-care is so important, everybody. Let's try to make an effort to take care of ourselves and our families, and for those people that we know that might be alone at this time. Okay, so thank you so much, Dr. Timothy, for answering my questions. I'll go to the chat now and see what people would like to discuss. All right. I think we addressed some of this a bit, but if you have any more specifics, how far behind is Canada in race-based stats?
We are really very, very far behind. What I think is that the last 10 months, it's given a catalyst for race-based data. And I know that I actually had a conversation with the Ministry of Long-Term Health recently. And I know that they're trying to create more avenues to collect race-based data, but we are very far behind if we look at countries such as the States, even UK. There's more race-based stats. The thing is that Canada kind of had this notion, and particularly within governance, that said, Canada is a very friendly country. Canada does not have the same, issues with race and racism, compared to the southern border in terms of the states, and in fact denied access of collecting race-based data based on kind of creating that kind of image of Canada, which is actually not true. So I think that it's a really good thing that we're having these discussions on race-based data, but I think it's also important to understand how we collect them, who collects them, and what the analysis of them is really important too, because there's a history of scientific racism and racism being a race-based data being used in a very negative way also, locally and globally. So I think that who collects it, why we're collecting it, and how we analyze it are really critical things to talk about also.
There's a related question here. What do you say to people that say race-based stats ghetto-size groups?
Right. I think that the notion of ghettoization is an interesting notion. It also is something that really is supported by people who purport racism in the state. So, Black people live in particular neighborhoods. They go to particular schools in the Canadian context, and then there's a notion of, well, Black folks are living in ghettos, or they're living in a particular way because they're not able to achieve other things. When in fact that we know ghettoization has to do with policy, right? It has to do with policy. If we look at the housing policy in the Canadian context, and we look at employment issues, we look at anti-Black racism, we know that the reason why Black and racialized and Indigenous folks are living in particular neighborhoods are because of anti-Black racist policies and actions. So I think that race-based data, if in terms of the question of ghettoicizes groups, I actually think that's not accurate, and I think it's a pretty problematic statement, because we need the stats to be able to prove what we already know, that racism impacts health, and also that to look at interventions that will make a change, and hopefully to not only decolonize our health, but to create wellness and being programs to support our communities. So I think that race-based data is not a ghettoization issue, but I think who collects it and how it's collected is really a critical question that we should talk about.
Thank you. I've always said, like, if we're not collecting it, then we don't know, we don't have any evidence to say that this is happening.
Right.
Therefore, in our negligence or in our ignorance, we say it's not happening, so nothing's being done about the situation, right?
100%.
Yeah, we can't keep on letting that continue.
Yeah.
Another question here is a big topic that we should be discussing. Can we discuss about vaccine hesitancy in communities of color?
Yes, I mean, that's a big question. It's important. I've been even this week I had 2 conversations, one national and one local, in terms of vaccine hesitancy. And I know there's also a Black task force that's doing vaccine equality right now, or equity. Again, we have to look at our history, right? We have to look at our history of vaccine hesitancy. I actually do not like that term. I think it should be called vaccine distrust and mistrust. And I can say that in March 2020, communities, Black community members particularly, talked about, that if the vaccine is coming, because we were hearing that this vaccine was being invented and coming, what would be the uptake based on the distrust, based on anti-Black racism in the community of this vaccine. So, I think that vaccine hesitancy or vaccine distrust exists based on the historical and current day experiences of anti-Black racism. Why would Black folks really trust what people are saying for vaccines based on the experiences of inequities that they have? However, I also want to say that there's many different Black people in the community. There's many folks who will say, "Hey, I want a vaccine. I want to be vaccinated, or I want to have that done." My thing is that I think it's important to have these discussions in terms of informed consent, informed information about vaccines. Black people, many Black people that I have spoken to or that have taken our survey so far, are not running to be the first in line to get vaccines. And that's based on their experiences of anti-Black racism. Now, also, we have to look at the government and public health. They also did not think about having a strategy in terms of vaccine distrust and addressing these issues earlier. And that's a problem, because we spoke about it, right? If they thought about it, we weren't prioritized. Recently now, they're saying in phase 2, we've already had phase 1 of vaccines. In phase 2, it starts in April 2021. They're saying that racialized older community members are going to be prioritized for the vaccine. Now, again, that doesn't necessarily address the vaccine distrust, in the community. So I think that the best thing is that people should be informed, and people should be able to make their own decisions about whether they have the vaccine or not, and how they keep on social distancing, keep on, wearing your mask, keep on doing those things. But vaccines are, it's a larger discussion, but it directly relates to anti-Black racism, and also not having access to information about vaccines in our communities.
Yes, thank you for answering that question. Yeah, that's a big topic, and I urge anyone listening that has these questions to do some research and get informed. And a good place to start that would be the Black Scientist Task Force that the City of Toronto has started this initiative, which is a panel, and membership is organized of professional Black healthcare workers, scientists, community workers that will provide some real life evidence and experiences around vaccines and some of the misconceptions that people have and conspiracy theories that people have heard through social media, and try to debunk those and just provide some sound information that everyone can understand so they can make their own informed decision about their health. Mm-hmm. Let's go to the next question. Are you aware of any services being offered to migrant workers in Canada since they're not eligible for Ohip?
Yes, there's been a lot of discussions in terms of migrant workers and services in terms of COVID-19. There's actually an organization, and sorry, it slipped my head right now. It's a migrant organization. I can't remember the name now, but they're offering services for workers. However, there's a lot of supports that are needed, particularly like in terms of food insecurity. Also, migrant workers who have COVID-19, we know that they're working less, so therefore they're not able to send the monies back home, which is why people become migrant workers. My cousin was a migrant worker back in the days. So there's a big need for more supports for migrant workers, particularly because they have less access to healthcare. There has been a policy passed, and this was after a lot of advocacy to support migrant workers in the Canadian context. So there are now getting healthcare supports, but there's still a lot of food insecurity and housing insecurities as they're living in crowded housing, and more importantly, their wages are being taken away. There was also an issue of deportation in the beginning, also of COVID-19. That's also been changed and challenged, but there's still a lot of disparities happening in terms of migrant workers in the Canadian context.
Thank you. We have another question here. How can people of color find information they trust, given the mistrust some have in the system? I believe they're probably talking about healthcare system here.
Right. I think that's a really good question. There's different community health centers. Women's Health and Women's Hands is a Black woman, racialized women's community health center. There's Taibu Community Health Center. There's different organizations of the task force, the Black COVID task force. There's different ways to get information. There is a lot of research that's needed, unfortunately or fortunately, that you kind of have to dig for the information. Now there's also a lot of panels. Like, one thing about the COVID-19, there's a lot of webinars on Black health and Black COVID-19 locally in the Canadian context, and also provincially and globally. So there is more information that you can get in terms of getting some information about COVID-19. The trust is something that you have to build. As a therapist, when I'm working with my clients in the beginning, we're building a therapeutic alliance, we're building trust, and I think it's something that's earned. Right? You have to earn trust, and the fact that the system is still not directly, dealing with anti-Black racism, we're having a lot of conversations, but we really need resources. If you really want to support, creating more access for Black folks in healthcare, you should have a national collaborative place and space, a committee that can actually, have monies, because it's about money, and also information that we can actually, create these systems or these healthcare systems that can actually improve access and care. So there's a lot of things that can be done. I think a lot of folks right now are still talking about confronting anti-Black racism. There's a lot of statements, but hopefully these statements will turn into practices and concrete, implementable ways to make changes in the community. And I think that will add to the trust and create more trust in the community. So right now it's more community health centers, word of mouth. There's a lot of things on the internet because we're not allowed to, be with people the same way. And those are some ways that we can get some more information. But trust is something that takes time and is earned. And it's going to take a while to do that. There's going to have to be many, many changes in our healthcare system. Thank you.
Yes, we want to see more statements transitioning to action. A lot of statements have been put out recently, as you said, and it's good to see that there are plans to address these things. But it looks like it's the Black community that's taken upon themselves to educate and provide that information, knowledge translation. So I think people are watching and they're seeing where they have fallen short and need to address those.
Definitely. And we all have, we're trying to survive and thrive as Black community members. We're trying to, be well. We're trying to deal with the impact of COVID-19 and the impact of many other things, other chronic illnesses. I think one thing that is a little bit challenging is the fact that, people, when you don't trust the system, when there's an emergency, people tend not to go to the hospital. They tend not to it's not their first choice, which means that it can lead to a more serious condition. So, people say, hey, I want to get back to the normal. I actually don't want to get back to the normal, because if the normal is, continuing to have violence against Black folks and racialized folks' lives in terms of health, that's not what I want to do. What I want to do is for post-COVID, and hopefully there will be a post-COVID, is to really do, emancipatory work and really have work that includes changes and has well-being and has healthcare services that Black folks and racialized folks can actually get good health and good services for. So that's what I want to see in the future.
Thank you. On that note, we will end our interview. I want to say thank you so much to Dr. Tim for answering our questions and giving us this wide knowledge about health inequities and COVID-19 in the Black community, racialized and marginalized community, Indigenous populations. So thank you again so much for taking the time out to speak.
Thank you so much, Kayla.
Wow, I want to thank Dr. Timothy once again. What a fantastic interview, what relevant information. And I also want to thank Kayla for doing such a fantastic job with the interview as well. I'm so proud of our youth team here that we are doing these kind of programs and also working on some cutting edge platforms. I want to give a special thanks to Joelle and Leanne that were running all the sort of the camera work and all the videos and transferring the questions, and to all of you that did send in questions. I hope you've been able to take something away from this that's been able to be useful to you. You know, we live in such a troubled world these days, and it's so important that we remember, you know, the Bible in all of this. You know, it talks about whether you eat or drink, whatever you do all for the glory of God. And it means also too, as we work and navigate the system of trying to understand, you know, the vaccine and our role in taking the vaccine, we also have to submit ourselves to God's will. And God wants us to be healthy. He wants us to be whole. We are all whole in Christ. And so ultimately, that is the goal that we must follow and hear God's leading as we make those decisions. I want to thank Dr. Timothy again. And, you know, we have on the screen her research. So if you want to go to that website, blackhealthmatterscovid19.ca, you can participate in that research, help get the data that we need. So our communities of color will be represented in future research, in future decisions that are meaningful and applicable to our communities as a whole. And also I want to say to Dr. Timothy that, you know, even though you're not a member of this church, you always have a home here at Apple Creek. So if you're ever by, please come see me, one of the members of the church. We'll find a good place in the pew once we open up, of course. And of course, there's always front row seating if you watch us online. So I want to thank you all again for participating. And we're going to close with prayer. And I just encourage you all to keep watching out for Your Mic is On here at Apple Creek, where we try to bring you both spiritual and informational things that you can use in your daily life. So God bless you all. And we'll turn it over now to Harmony for our closing prayer.
Dear God, thank you for bringing us together. Those took time out of their days to plan it all. Thank you for the woman who spoke and gave us this information that we are going to take and apply to our lives every day. Be with those who are unable to join us today and remind them that we are here and that they can reach out to us whenever they want. Thank you for blessing this Sabbath and giving us another one. I hope to see everyone next Sabbath as well. Stay close with us and keep us in your heart and remind us that you're always here with us. Keep everyone safe and bless those and pray. And I pray for those who are impacted by COVID. And I hope that they get this information, they can apply it to their lives. In Jesus' name, amen.